C-sections. It's often a word that can invoke feelings of uneasiness, discomfort, pain, and even guilt. But C-sections aren't necessarily deserving of such negative connotations. In fact, C-sections or cesarean births often can alleviate immediate pain, reduce complications, and even save the lives of both baby and mother. A cesarean birth is a process or procedure where the fetus is delivered through an incision in the abdomen, thereby circumventing the birth canal altogether. While vaginal birth is generally promoted for low-risk patients as the best route for delivery, some pre-existing conditions can necessitate a cesarean operation. These complications can include placenta previa, a condition where the placenta lies over the cervix either partially or completely, thereby blocking the baby's descent. Breech position is another consideration that can require cesarean intervention, though this is typically addressed before labor progresses too far in order to reposition the fetus in a vertex position so that the head presents first. However, if the mother presents with adequate cervical dilation, repositioning is often a foregone conclusion. In this situation, in order to prevent hypoxic ischemia to the fetus in a vaginal birth, the primary care provider or physician may elect to perform a C-section. Other complications that may also preclude vaginal birth as an option can include fetal distress, higher order multiples, and finally, previous history of a cesarean birth. However, a previous history of delivering via cesarean doesn't generally preclude one from attempting TOLAC, or trial of labor after cesarean. In fact, a gravida 2 mother with no other complications would theoretically make a good candidate for attempting a vaginal birth. The Center for Disease Control found an increase in VBAC, or vaginal birth after cesarean rates, growing from 12.8% in 2017 to 13.3% in 2018. Though this isn't a large increase, it does support the World Health Organization's efforts to reduce unnecessary C-sections from the estimated 32% where it stands now globally to only 10 to 15%. The following excerpt from the WHO clarifies the justification for reduction well and states, "Since 1985, the international healthcare community has considered the ideal rate for cesarean sections to be between 10% and 15%. Since then, cesarean sections have become increasingly common in both developed and developing countries. When medically justified, a cesarean section can effectively prevent maternal and perinatal mortality and morbidity. However, there is no evidence showing the benefits of cesarean delivery for women or infants who do not require the procedure. As with any surgery, cesarean sections are associated with short and long-term risk, which can extend many years beyond the current delivery and affect the health of the woman, her child, and future pregnancies. In addition, the international community has increasingly referenced the need to revisit the 1985 recommended rate. To conclude, unless medically necessary, there's little evidence that a CS or cesarean section can promote maternal or fetal health over a traditional birth. But what else can healthcare professionals do in the meantime? While the rate of nearly 1 out of every 3 newborns being delivered by CS is hoped to decrease in the coming years, there are others who are seeking to improve the cesarean process altogether. Enter the Society for Obstetric Anesthesia and Perinatology, or SOAP, which was founded in 1968 and seeks to improve pregnancy-related outcomes of women and neonates through the support of obstetric anesthesiology research, the provision of education to its members, other providers, and pregnant women, and the promotion of excellence in its clinical anesthetic care. In May of 2019, SOAP formulated a protocol based on evidence-based practice which seeks to improve the recovery rate and overall experience for mothers who will be having C-sections. The consensus statement titled Enhanced Recovery After Cesarean documents interventions that could drastically enhance the cesarean birthing process altogether. By improving proven techniques and implementing new standards, SOAP has found new ways to reduce the recovery time and minimize complications that typically arise in the process. ERAC protocol aims to standardize the perioperative care of the pregnant patient by reducing variabilities in care and creating a specific evidence-based care pathway, thereby improving maternal and fetal outcome. These guidelines are further broken down into preoperative, intraoperative, and postoperative interventions. I hope you like acronyms because more are coming. While the American College of Obstetrics and Gynecologists, or ACOG, have long stood that patients should be NPO prior to undergoing regional anesthesia for fear of aspiration during the procedure, the SOAP has issued improved guidelines that slightly contradict this prior standard. Preoperatively, patients are recommended to limit their fasting period before the procedure to only 6 hours and can have clear fluids up to 2 hours before. This recommendation still limits aspiration risk while limiting dehydration. Additionally, non-diabetic mothers who are encouraged to drink up to 32 fluid ounces of Gatorade or similar electrolyte-enhanced drink 2 hours before the procedure, as this will reduce maternal hypoglycemia and reduce metabolic stress. Patient education is also an important factor that improves patient compliance and reduces complications, and it is recommended that patients be seen the day before the procedure if possible to cover preoperative instructions and evaluate maternal lab values. Which brings us to our next topic, hemoglobin. All expecting mothers should have their hemoglobin values assessed, as a diminished value could indicate the patient is suffering from anemia. Additionally, antepartum anemia is a significant predictor of postpartum anemia, which is linked to depression, cognitive impairment, and fatigue. Furthermore, maternal iron deficiency anemia can increase the risk of low birth weight, preterm delivery, and perinatal mortality. So in review, preoperatively, we want to limit fasting to only 6 hours, encourage plenty of fluids, particularly electrolyte carbohydrate drinks, for non-diabetics up to 2 hours before, and provide education and evaluation up to and including the day before the procedure if possible. Intraoperative interventions are done while in the healthcare facility or birthing center. One of the first recommendations is to limit the usage of IV fluids. The SOAP recommends that no more than 3 liters of intravenous fluids be used before, during, and after the procedure. Previously, IV fluids not only increase patient hydration, but reduce the risk of spinal anesthesia-associated hypotension, a somewhat common complication that accompanies regional anesthesia. Rather, the SOAP recommend that vasopressors, such as phenylephrine, be used to prevent hypotension. They concede, however, that these guidelines may need alteration for women suffering from gestational hypertension or preeclampsia, as vasodilation may be a therapeutic side effect of anesthetic innervation. Vasopressors, such as phenylephrine, also reduce the risk of IONV, or intraoperative nausea and vomiting, as this is a rather common maternal stressor associated with moderate to severe hypotension. Furthermore, uterotonic meds, such as Pitocin, should be administered in the lowest effective dose, which achieves sufficient uterine tone while reducing the side effects of overmedicating, such as hypertonicity. Lastly, non-opioid analgesia should be administered alongside standard opioid analgesia prior to the onset of pain. In summary, the intraoperative period should see limited intravenous fluids, vasopressors to reduce hypotension, taking into account gestational hypertension and preeclampsia, minimum uterotonic meds, and analgesia pre-medication before onset of pain. These factors can greatly reduce intraoperative complications and enhance the postoperative recovery rate. Postoperative interventions are where we begin to see an increased recovery rate due to the accumulation of prior care provided combined with postpartum care. Here we will want to begin with ice chips or fluids within 60 minutes of admittance to the PACU, and advance to a regular diet as tolerated within 4 hours. Early oral intake can accelerate the return of normal bowel function, reduce the length of hospital stay, and reduce the risk of postoperative nausea and vomiting, which benefits the patient greatly. Additionally, the patient should ambulate soon after the return of motor function as tolerated. Between 0 to 8 hours, patients can sit on the edge of the bed, move from the bed to the chair, and even void voluntarily if able, once the urinary catheter is removed. Between 8 and 24 hours, patients should be encouraged to ambulate once or twice down the hall as tolerated. And between 24 to 48 hours, patients should be encouraged to walk 3 to 4 times down the hall and stay out of bed for up to 8 hours to promote recovery. Early mobilization decreases muscle atrophy, hypoxia, DVT occurrence, and insulin resistance, all while reducing the patient's length of stay. Additionally, clustered care should be employed to promote rest. Try to combine vital assessments with analgesia administration and postoperative monitoring, including to observe for signs of venous thromboembolism, as cesarean delivery approximately doubles the risk of occurrence. To sum up, post-op care should see the patient returning to a normal diet within 4 hours, patient ambulation is tolerated, clustered care, and reduced use of opioid analgesics to promote patient recovery. This improved protocol mirrors the ERAS, or Enhanced Recovery After Surgery model, which has seen marked improvement in patient recovery since its incorporation by various hospitals in 2017, both within the U.S. and abroad. So knowing what we know now, how can this ERAC, or Enhanced Recovery After Cesarean protocol, be applied to the individual? Well, first, let's assume that our patient is receiving prenatal care. She's 29 years old, pregnant at 39 weeks gestation, and already has two children ages 5 and 3 that were both delivered via cesarean due to breech presentation on both occasions. She's 5'4", weighs 165 pounds, her BMI is 28.3, and she's gained 25 pounds thus far since conception, and has no known allergies and no other comorbidities. Since she's receiving prenatal care and she's near the end of her 3rd trimester, she's being seen weekly and has a C-section scheduled for tomorrow at 3 p.m. The day before, we want to see this patient to evaluate her labs and ensure fetal well-being, along with educating her about the fasting regimen, which dictates no solid foods 6 hours before the operation and fluids up to 2 hours prior, which means she can eat breakfast before 9 a.m. the following day and drink plenty of fluids, including a recommended Gatorade or similar electrolyte carbohydrate drink before 1 p.m. When she arrives at 2 p.m. for her 3 o'clock appointment, the healthcare staff would perform an admission assessment which includes past surgical history, secondary illnesses, allergies, reaction to anesthesia, and current medications, then begin prepping the patient for the OR. ERAC protocols would see limited intravenous fluids, vasopressor administration to counteract the local anesthesia epidural-induced hypotension, and finally, analgesia administration after delivery of the newborn. Medications used during this period would include phenylephrine, a vasoconstrictor that reduces hypotension-induced nausea and vomiting, narrow-spectrum antibiotic prophylaxis to aid in recovery, such as Ansef, Pitocin, a synthetic form of oxytocin used to aid uterine contractions and prevent hemorrhage, and finally, opioid analgesics such as morphine in tandem with non-opioid analgesics like Tylenol or ibuprofen. Assuming there were no complications with the procedure, post-op ERAC protocols would dictate that the mother would be able to return to her normal diet as soon as 4 hours after the procedure, which typically takes 45 minutes to an hour, meaning she can eat at 8 p.m. and ambulate as soon as 10 p.m. if she can tolerate it. 3 unique nursing diagnoses for this particular patient could possibly include increased risk for DVT related to increased blood coagulability, increased risk for infection related to postoperative wound, and acute pain related to postoperative wound, which all differ from a postpartum mother who has delivered vaginally. Though enhanced recovery after cesarean protocols are established for scheduled C-sections, many components can be utilized in non-scheduled cesarean deliveries as well. Ultimately, however, success of the ERAC program lies in interdisciplinary collaboration along with patient cooperation. Thank you.